We'll move on to the next session. It's a case scenario based discussion on acute pancreatitis. I would like to first invite our panelists, Dr. Ajoy Sarkar sir, Dr. Prateik Poddar, Dr. Rajesh Barasia, and Dr. Nikhil Sonthalia. Now I call upon the moderator, Dr. Jayanta Mukherjee sir, to kindly come and conduct the panel discussion.
Good evening, everybody. We'll try to make it as short and as informative as possible. We have got 4 panelists. I will be asking questions to each of them and we'll trying to highlight whatever they try to answer. So the first case is a 45-year-old male patient. First day, history of pain, abdomen, severe, continuous, radiating to the left infrascapular region. This is the first episode of pain. Recurrent non-voluminous vomiting, stooping forward during pain, distension of the abdomen, minimal flatus. He is a non-alcoholic without any addictions and there is no comorbidities. So Dr. Barasia, what would be the differential diagnosis when you get a patient of this kind in the ICU or in the emergency?
Yeah. Can I have the previous slide, please?
Oh, sorry.
No, previous slide. Yeah. So he's a male patient with a pain radiating to left infrascapular region, profuse vomiting, non-voluminous vomiting, sorry. Stooping forward itself gives one's the primary diagnosis to be acute pancreatitis, because that's the position when a patient with acute pancreatitis is most comfortable with. But with all these symptoms, first thing which I would rule out is acute myocardial infarction. And all the causes of acute abdomen will have to be ruled out. Primarily perforative peritonitis, acute cholecystitis, acute peptic ulcer, mesenteric ischemia, definitely, and renal colic.
So these are the commonest which we would think. Of course, as has been pointed out, recurrent non-voluminous vomiting goes in favor of acute events like either peptic ulcer disease, biliary colic or pancreatitis, and the duration of the pain usually suggests what type of pain it would be. So pain of pancreatitis is typically epigastric or left upper quadrant. It's described a constant pain. It is a non-colicky type of pain with or without radiation. Duration is important. It is usually in days, not in few hours. Usually associated with non-recurrent, non-voluminous vomiting. Pain described as severe but can be variable, and intensity and location does not correlate with the severity. So on assessing the patient in the emergency, it was tachycardia, BP of 140/90, tachypneic, tender, distended, firm abdomen. Peristalsis was sluggish on day 1, but the patient was conscious and oriented. So the next question would be, which patient requires admission? So what would we suggest? Admission in the ICU or a monitored bed or a ward? So Professor Ajoy Sarkar, please.
Thank you. Going back to the scenario, the patient saturation is not mentioned. So what was the oxygenation?
Saturation was normal.
Normal. And then doesn't have any organ failure.
Clinically,
it seems that he is a mild pancreatitis, not even moderate, I would say. So in that situation, they can be kept in the ward jolly well, but obviously they can go to moderate or severe at any point of time. So one must monitor vigorously, and there has to be monitoring in terms of organ failure and in terms of hypotension, particularly.
But we are in the emergency now. We have not assessed the patient as such in terms of.
So can be triage could be to any ward, and preferably if you have a gastro ward where the sisters knows, because it all depends on the background scenario, because we do have gastro-respiratory ward, preferably those who have got a tendency to, like in respiratory failure, If they are fine, even then we keep them into respiratory ward so that they can fall into respiratory failure at any point of time. So sister can identify because doctor will not be always there.
Sure. This patient was admitted in the ward, but of course we have got a simple, there are multiple scoring for pancreatitis which can identify whether a person is going into a possible organ failure or serious indication for ICU admission. But this is a small score, which is a bedside score, which of course measures, as you have mentioned, blood urea nitrogen, mental status, systemic inflammatory response, age, if it is more than 60, and pleural effusion. If any of 3 or more of this is considered indicative of possible severe acute pancreatitis. So this person does not definitely qualify for any of these, and the person was admitted in the ward. But few things to remember, most episodes of acute pancreatitis are mild and self-limiting, and as has been mentioned, can be managed in the ward. 20% develop a moderate to severe acute pancreatitis requiring a prolonged hospitalization, monitored bed ICU. When they present, they are never usually the severe disease. They are usually in the early stages of early organ failure or maybe early pancreatic necrosis, very difficult to diagnose in day 1. We have to remain vigilant for the development of severe disease and organ failure during the initial 48 hours. So therefore, it is important when they come to the ICU, even if they go to the ward, we have to remain vigilant whether they are going to possible development of acute pancreatitis. Once the patient is admitted, we would prefer to give the fluids. So the first choice question would be to Dr. Prateik Poddar, what would be the choice of fluid in a patient of acute pancreatitis admitted in the ward?
So sir, fluid therapy is always the crux of management of acute pancreatitis, has been a topic of various studies, various discussions. Some studies are suggesting something the other. But in general, ringer lactate has been found to be definitely the fluid of choice. There are some data now to suggest balanced fluids can also be a good option in these patients. So that is, these two are something which we are looking at mainly.
Okay.
I think ringer lactate, because balanced, crystalloids are very expensive, but ringer lactate is very good. In some papers, it has mentioned that it has got an anti-inflammatory effect in addition to fluid replacement. So I would rather go by ringer lactate.
The fluid of choice is definitely ringer's lactate. So the next question is, even if we give a fluid, what will be the amount of fluid which we would prefer to give in day 1 to this person who is possibly having a significant amount of fluid loss? Dr. Nikhil.
Yeah, so a general concept that we just overload the patient with fluid does not work nowadays. The waterfall trial, the landmark trial that we have in AGM clearly told us that goal-directed therapy, so urine output of 0.5 to 1 ml per kg, we want MAP more than 65, we want IVC collapsibility index to be assessed, we want hematocrit to be less than 44. So we want a fluid of 1.5 ml per kg per hour. If patient is in shock or in hypovoluminous state, then a bolus fluid of 10 ml per kg can be given, and then reassess every 6 to 12 hours for initial 48 hours.
Okay, what has been highlighted once is lactated ringer's fluid is the fluid of choice preferred over normal saline. Reduces pancreatic injury, as has been highlighted, has causing decreasing of inflammation also. It is pH balanced, whereas normal saline being at some degree of acidic fluid can cause some degree of renal injury and of course some degree of metabolic acidosis. Assessment of fluid transfusion, we measure the dynamic parameters, that is heart rate, blood pressure, urine output. The aim is decrease the hematocrit, decrease the blood urea nitrogen. These are the two targets which we aim for, apart from which has been already highlighted, urine output. The testing of laboratory evaluation should be done every 6 to 8 hours to assess whether the person is responding. After admission, every 6 to 8 hours, a regular assessment needs to be done. And the amount of fluid, if the person has got no evidence of hypovolemia, it's approximately 1.5 ml per kg body weight per hour. And if the person has a hypovolemia, administer bolus followed by this amount of fluid, 1.5 ml per kg body weight per hour. But remember, the fluid loss in these group of patients, either by respiration or third space loss, is around 3 to 4 liters in the first 24 hours needs to be administered. Caution, of course, cardiac renal diseases causing volume overloads, pulmonary edema. And once a patient has severe disease, that is important. If the person has got severe disease has already set in, this is the time when aggressive hydration or overhydration may be harmful. it is on the day 1 which is most important that the fluid is to be given. The amount which has been quoted is on day 1 of pancreatitis. Once they come to the tertiary referral centers of 3 or 4 days of pancreatitis, this is the time when overhydration may be more harmful than beneficial. Coming to analgesics.
Just on that point,
Yeah.
2 additional bedside assessment that we do in our unit, lung ultrasound to see the B line and bedside echo. That can give you a very good direction of how much fluid you can overload in next 6 to 8 hours,
As
in
mentioned.
addition to burn and hematocrit.
As mentioned by Dr. in the previous lecture, the dynamic parameters of assessment of fluid intake. Coming to analgesics, which would we prefer in acute pancreatitis?
In acute pancreatitis, usually there are 2 sets of analgesics which we use. One is NSAIDs to start with, and if we do not control with NSAIDs, then we add on some opioid to it. Usually starting with,
We start off with diclofenac as one of the commonest analgesics, which usually in a setting of pancreatitis is not very effective. We switch over to tramadol, pentazocine, meperidine, morphine, and rarely we have got the newer generation of anesthetic agents which can be given to control the pain. Coming to the antibiotics, what situation in which you would prefer to give antibiotics in this group of patients? Would you prefer to give? Dr. Sarkar, please.
Just one point we need to remember, that there is no role of prophylactic antibiotic in pancreatitis unless there is hard evidence of infection. I'll come to that, what are the hard evidences. But every pancreatic patient will be behaving like SARS, not sepsis. It will have all the criteria of sepsis, but it is SARS, and there is no infection. So here we should not give any prophylactic antibiotic. Even if in this patient is no question, and provided a patient who has got a pancreatitis and also has got other signs of infection, say pneumonia or UTI or bloodstream infection, you have sent a blood culture which is positive for some other reason, then perhaps that is a different ballgame. You have to give antibiotic. I cannot sit on that. But isolated pancreatitis with mild, even with moderate, even with severe, no signs of infections, then should not have any antibiotic.
Agreed. Dr. Poddar,
So very nicely detailed by sir, but it's very important in this patient also, because non-alcoholic patient with pancreatitis, very important that we need to rule out cholangitis, cholecystitis, and that is a very important point where antibiotics might be required. So we don't have the lab parameters yet, and that is a very difficult sometimes decision to make, whether with the ongoing SIRS for pancreatitis, the patient is actually having inherent cholecystitis or cholangitis at the present moment or not. And there are certain markers, but yeah, we can go forward.
The problem which we face is all patients of acute pancreatitis, whenever they are admitted, either the patients under the undue pressure by the patient's relatives, or we also prefer to give them antibiotics. So this is something which we should not be doing. Antibiotics need not be given to a patient who has got a mild pancreatitis on day 1 until unless we have got proven evidence of infections like UTI, pneumonia, cholangitis, etc. And of course,
in my hospital, if we have 10 pancreatitis in a year, say only one will get antibiotic within 7 days. None of them, even if it has been written in the ED department, next day consultant will come and strike off that antibiotic.
ideally we should have a protocol. We don't have a protocol, that's why everybody does as they like. So antibiotics are given on day 1 to majority of the pancreatitis patients. And of course, this is, I'll come to later. Coming to the labs, the amylase, as you can see, is very high, lipase is high. Dr. Poddar, could you give us does the severity of the pancreatitis depend upon the level of amylase lipase?
No, absolutely not. So this is an oft-asked and oft-discussed question, especially with the intensivists and all the physicians that we discuss with. The lipase amylase basically has a diagnostic value. The quantum of the elevation does not have any cause for concern as a severity of the pancreatitis. Of course, they tend to decrease over time, but there are certain reasons why they may remain elevated, including collections, including disconnected ducts and other causes as well. But in general, lipase amylase mainly has a role for diagnosis, and serial monitoring of the lipase amylase levels usually, in most scenarios, does not have a significant role, especially otherwise in special scenarios.
Dr. Sonthalia, would you suggest, as you
Yeah,
said,
so
sequential?
it is very clear a misconception that sometimes we see that doctors chase the amylase lipase. It has only as a diagnostic role. It does not correlate with overall organ dysfunction or patient outcome. What drives severity in acute pancreatitis is inflammatory cascade. And the markers of inflammatory cascade are not amylase and lipase. So, as Dr. Prateik told, in very specific situations, when we are suspecting pseudocyst, when we are suspecting persistent PD obstruction, when we are suspecting occult malignancy in ampullary or head area which is causing PD obstruction and dilatation, there you can have persistently raised amylase lipase which can raise an alarm. But in routine cases, just the diagnosis, it should not be chased or follow up to prognosticate or counsel the relatives as well.
One point just I would like to highlight in this scenario, a patient who's, not in this patient, but in a patient who is a known case of chronic pancreatitis, who's had recurrent acute pancreatitis episodes, sometimes the lipase amylase might not elevate. And that is something which you need to keep in mind, that the patient may actually be having acute pancreatitis on the CP, but without the elevation. We need to look at that.
So the take-home message would be, the take-home message would be amylase and lipase do not have a prognostic value, only a diagnostic value, so they need not be repeated again and again. Diagnostic value is important when the level rises more than 3 to 5 times the normal value. If there is a doubt regarding the possibility of pancreatitis, always ask for imaging and not depend upon only amylase and lipase. Sequential, no reason to follow up. Amylase rises earliest, gradually comes down. This is the time if you want to detect pancreatitis on day 2, day 3, day 4 of pain, you have to go for lipase rather than amylase. So this is the CBC on day 1. TLC is raised, hemoglobin is 18 grams %, PCV of 50. Dr. Sonthalia, what would be the interpretation of WBC and the role of antibiotic in this situation?
Yeah, so WBC of 18,000 in most of the cases of pancreatitis is due to inflammatory response on day 1. So SIRS, severe inflammatory response syndrome, is one of the prognostic markers in the BISOP criteria, and that results in majority of the patients having raised leukocyte. It does not mean infection. If you are suspecting infection, there has to be hard evidence like an air in the peripancreatic area or extrapancreatic evidence of infection. But it has a prognostication value. A patient presenting with high leukocytosis in initial 48 hours may suggest progression towards severe pancreatitis because it's an indirect evidence of hyperinflammatory response with increased interleukin 6 and procalcitonin. And hemoglobin of 18 again suggests dehydration, so this patient needs fluid resuscitation, and leukocytosis just should not be chased. We can send the septic profile and await, but we should not start antibiotic at this point.
So this is again a significant take-home message. WBC significantly raised on day 1 does not warrant any antibiotic until unless we have got hard evidence of infection proven by either by culture or other methods. This is the liver function test, which shows some degree of bilirubin rise. SGOT, SGPT is high, alkaline phosphate is 2 times normal, albumin normal. Dr. Barasia, is this sufficient for you to suggest any or blood tests, or you are happy with this blood test for a possible etiology? And what would you comment upon by seeing this test?
This would suggest biliary pancreatitis, definitely.
Okay. Mike's question.
These reports will definitely suggest a biliary pathology.
Okay.
Biliary, pointing towards biliary pancreatitis.
So this is the commonest protocol which we commonest level of bilirubin and SGOT, SGPT. When we see this level, we suspect it is a biliary pancreatitis, the stone having possible passed out through the or into the common bile duct and causing this change of LFT. So this is the renal function test on day 1 showing a rise of urea and creatinine. Dr. Sarkar, how would you interpret this, and whether you would like to intervene in some way in this?
Definitely creatinine is raised, urea and creatinine, and probably has developed AKI. Now question is, AKI in acute pancreatitis is a very common complications, and it can happen because of various reasons. One is due to dehydration, which if you don't correct volumes properly, Second, they can have a huge intra-abdominal pressure, which might compromise with your renal circulations. Third, they can have as I mentioned, that it's a SARS. So sometimes with the cytokine storm can also affect the kidney. So these are the reasons one can have, raised renal function. But with 1.8, we need to correct the hydration first and see whether it's coming down or not. If it is not day one, then you have to consider that he is developing organ failure.
So a significant rise of urea and creatine day one, do not get alarmed, replenish fluid, reassess, see whether the urea creatine are going down. Usually they go down. So on day one, if the parameters improve, then we can relax. This is the ultrasound showing gallstones multiple, small. CVD is non-dilated and clear on ultrasound, pancreas bulky with minimal ascites. Dr. Santalia, would you prefer any other investigation for CVD apart from the added, which we usually ask for, CT and MR? Would you ask for any other investigation to assess the CVD?
So endoscopic ultrasound is a very good modality which has 99.2% sensitivity in picking up small calculi of 2 millimeter, 3 millimeter, which can be missed by an MRCP. So I'll go by clinical assessment. I'll monitor serial LFTs. If the LFT is spontaneously coming down, I may wait before doing any invasive procedure. So what I will do in this scenario, I'll do an MRCP which is non-invasive and more comfortable for the patient. If MRCP is conclusively telling me that CBD is normal, I'll sit tight on him and monitor my LFTs. Once the LFT shows a downward trend, I may not intervene, but if LFT is static or patient develop new onset fever or new onset abdominal pain or any other new onset organ failure, I should suspect cholangitis, then I'll go for a diagnostic endoscopic ultrasound, which can detect a small calculi or even a microcalculi or sludge in distal CVD, which can be missed in 4 to 5% cases by MRCP. So it has to be a clinical decision based on serial LFT monitoring.
So if you are suspecting stones, the first investigation would be CVD stones. First investigation would be a LFT. Second would be ultrasound. Yet it's suspected, ask for an MRCP. If MRCP is clear, clinical parameters are in favor of suspected CVD stone, then as suggested, we go for EUS.
One thing is that endoscopic ultrasound, it's not a usual procedure done in every center.
Absolutely.
Number one. And expertise, you need to have expertise.
Agreed.
But I would rather go for MRCP first.
Agreed.
If MRCP says that something is sitting over there, then you know that is close. If your MRCP is inconclusive, probably you have to go for, because that needs expertise.
So MRCP has a good positive predictive value. Its negative predictive value may not hold if patient is showing persistently deranged LFT or any new onset worsening of fever or pain.
So EUS comes as one of the last options for suspected CVD stones.
Especially for distal CVD stones. The distal CVD small stones, like you mentioned, very difficult with the MRCP to pick up.
Coming to the next parameter which we usually ask, a contrast enhanced CT scan. Dr. Barasia, when to perform this CT scan and why should it be performed?
Well, we perform a CT scan usually to see necrosis, and for necrosis to set in, at least 4 days from the onset is required. So a CT should never be performed within first 2 to 3 days. First CT should be performed within 4 to 7 days of pain. And subsequently, if the patient doesn't settle down, we can again repeat after, say, 7 to 10 days.
The only indication of an early CT scan in a case of suspected pancreatitis would be confirm the diagnosis. Thereafter, when we do a CT scan, it to prognosticate. So therefore, a CT scan, if required, would be at the end of 3 days. Or Sandali, you want to say anything?
Yeah, so this is the classical teaching that you should wait for 4 days for necrosis to set in, so you don't underdiagnose or underestimate the severity. But there are certain situations like patient is having abdominal compartment, or patient you are suspecting ongoing ischemia, or your diagnosis is in doubt, amylase lipase is not adequately raised, then you can consider early CT as well.
And also a point which is against a CT also sometimes, that if it's a mild pancreatitis, you may not actually need a CT in all scenarios. So if the patient's pain is settling down, patient is improving the next 3-4 days, you might defer a CT and you might not need a CT at all in such cases.
So though this patient was not a patient who ideally required a CT, this was a CT finding, diffusely bulky pancreas, no necrosis, some degree of free fluid, gallstones, non-dilated CBD. So the clinical progress of this patient, as it was mild, the pain subsided in 2 days, distension reduced within 3 days, flatus was passed. This is very important. Flatus passage is very, very important. Urine was initially high colored because of dehydration, improved, thirsty from day 1, hungry from day 2. So what would be the right time to give him a nutrition, or what other methods of nutrition would you prefer to have? Dr. Sarkar, please.
Nutrition within 48 hours, and in this scenario, I would say that within 24 hours, one has to start nutrition and has to be enteral nutrition. And if he can tolerate orally feed, is as good as any, so you don't have to put any tube. But if he is vomiting, cannot tolerate oral, then nasojejunal feed probably is better. Or the studies have shown that nasojejunal and nasogastric doesn't have much difference. But there is a notion that if you put something beyond the pancreas, then your pancreatic stimulation by the enzymes will be less. These are, I think, more theoretical than practical. So otherwise, but in my practice, if I always try by oral, if they can tolerate and there is no pain after giving fluid, then always go by liquid first, of course, and liquid has to be less fat. Then you go for next day with a semi-solid diet. Okay. And reason oral is always better than parenteral. One is you are keeping the gut integrity intact. Absolutely. There will be less translocation of bacteria, and the chance of complications related to parenteral nutrition, we all know, doesn't arise here.
Agreed.
So that is the...
So this patient would require early oral feeding because we maintain the gut mucosal barrier. And what to feed? As is mentioned, it's a mild pancreatitis. We usually do not go for liquid feed nowadays. We go for a low residue, low fat, soft diet. If tolerated, escalate. But remember, peristaltic sounds, if they are audible, is one of the best signs. Patient hungry is another sign. Third, flatus passes is the best sign when to start feeding. Dr. Prateik, anything?
Absolutely, sir. So recent meta-analysis have also shown that anything within 72 hours, so if starting feeding within 72 hours has the best outcome, and very early refeeding does not have any benefit, but within 72 hours is good. And this is the best thing, low fat, soft diet, that is what we recommend initially as an initial feeding measure, and has been found to be of similar value as if you start a nasogastric feed, if the patient can tolerate the feed. But the main thing is feeding toleration is very important for the patient. And that is it. So
what would be the right time to discharge this person? If he has a tachycardia, BP stable, tachypnea settled, what would be the right time to discharge this patient?
So basically the patient who is, the main discharge criteria is clinical in most scenarios. A patient who is able to tolerate a diet, who is not having any nausea, vomiting. Even with the high pulse and the SIRS, if the patient is now settled, this patient is in the right time to discharge the patient. So SIRS features which are in the downward trend. The patient is showing signs of improvement, feeding has been restarted for the patient, flatus is being passed, bowel is, sometimes even bowel is being passed, then the patient can be discharged.
Dr. Santaria, can leukocytosis be a consideration for holding back the patient from discharge? Leukocytosis of maybe 20,000. Would it be a consideration of holding back discharge? How many days you're talking? 3 to 4 days. He has improved in 3 to 4 days.
Only leukocytosis will not be the criteria. If he's in SIRS, I will wait. We should remember that generally the local complications set in the second week of the illness. The infections in the peripancreatic bed set in the second week of illness. So if the counts are on the rising trend at the end of day 5, I will be cautious before discharging. Another thing, since this patient had a gallstone, right, on USG. Agreed. So a mild pancreatitis patient in gallstone, I will try to consider surgery in the same admission.
So that's the next question is, Dr. Barasia, is when would you prefer to solve the surgical problem of the gallstone?
Once the symptoms of SIRS have come down, in this patient, I would like to operate in the same sitting before discharge.
Okay. So the best thing is the mild pancreatitis, clinically mild, radiologically mild, with biliary pancreatitis, operate in the same sitting. If you keep the stone and discharge the patient, there's a possibility that the patient may be readmitted again with an episode of acute pancreatitis.
I think that is the guideline as well, because it has been found through studies that the patients who actually not done cholecystectomy at the time of admission, a lot of proportion, 20-25% drop out of the cholecystectomy, and they don't end up doing the cholecystectomy and they come up with a second attack. So it's better that the cholecystectomy is done on the same admission, if possible. Otherwise, you have to wait for 4 to 6 weeks for the next session to be done.
Sonthali, if the patient has significant comorbid problems with gallstone disease, inability to operate, what would be your line of management of this person?
So if there is no cholecystitis, we will prognosticate the relatives that he may have a second attack. There is no role of prophylactic percutaneous cholecystostomy. If there is associated cholecystitis, we may consider a percutaneous cholecystostomy. There is an out-of-the-box thinking of doing EUS-guided cholecystogastrostomy, where we, if the gallbladder is distended and inflamed, we can create a stent-guided fistula between gallbladder and stomach, and we can create a passage for these very specific niche of highly comorbid patient whom you don't anticipate to undergo cholecystectomy in next 3 to 6 months.
What about sphincterotomy?
So, prophylactic biliary sphincterotomy during an attack of acute pancreatitis may not be justified.
Prevent an attack.
So, patient is still recovering from acute pancreatitis, and if there is no cholangitis, we should not attempt ERCP, because ERCP in acute pancreatitis itself is a different ball game. Yes. Your success rate reduces, chances of inducing pancreatitis increases. So, I may consider that on follow-up, but during an acute attack, I will be refrained from doing a prophylactic sphincterotomy.
Okay. So thank you all. The first session would be lactate. Is the criteria of fluid is lactate. Hemodynamic status is important. Measure blood urine nitrogen hematocrit. Aggressive fluid is not to be given. Resuscitation in the first day is very, very important. No prophylactic antibiotics. Routine administration antifungal agents not to be given. Early attempt at oral feeding. Initial oral feeding with low-fat diet in a mild acute pancreatitis needs to be done. Gallbladder surgery in a mild acute pancreatitis in the same sitting preferably. Advanced pancreatitis, postpone surgery.
I've got one
Thank
question. Should we give anticoagulant?
Severe acute pancreatitis we routinely give. In mild, we may not give, because deep vein thrombosis has been shown to be a prognostic factor in severe acute pancreatitis.
It's a very controversial topic, because there are people who are this side and that side of the fence. Some advocate addition of anticoagulation, but unfortunately there have been instances and data showing increased bleeding risk. Even with severe pancreatitis, there has been incidence of severe bleeding risk. So physical methods of prevention of DVT has been one point, but unfortunately they also end up with mesenteric vascular thrombosis and so on and so forth. So anticoagulation, like you mentioned, severe acute pancreatitis, definitely we should think.
AGA guidelines clearly say severe acute pancreatitis
you should give, yes. But the risk is always
yes,
mentioned.
Excellent. Moderate pancreatitis. It is hardly matters how you are going to manage. Standard of care, whatever you have spent, it is perfect. But if you are managing a severe acute pancreatitis with organ failure, in first 72 hours, when your patient in CRRT or in inotropic support or in respiratory support, totally a different ball game from the management perspective. So I will highlight 2 points, whatever the discussion is there. One is the nutrition point. Every conference we content NG versus NG is equal, same thing, all. I never believe this, because subset of patient, suppose your NG aspirate is 1.5 liter or 2 liter, how are you going to feed this patient with your NG tube? No chance. If your patient in BiPAP, PCO2 of 65 or 50, and you try to give carbohydrate-based diet, how you can improve your patient? Your patient is ultimately going to on ventilation. In this case, if you are using FRECA trilumina or nasogastric tube is 3 lumen or 2 lumen, 1 lumen in the nasogastric jejunum and 1 in the stomach, so you make a continuous drainage from the continuous thing from the artery spirit like the thing, and at the same time you can start the feeding. Point number 1. Second, in the pain management. Pain management is something, sometimes tramadol is the choice we used to give and said WHO later, but nowadays, what we are practicing, because we are privileged to have a dedicated GI critical care and we have a lot of pancreatitis, patient control analgesia. In morning session also we are discussing patient control analgesia with fentanyl or with buprenorphine. It is working, good working. It's our clinical experience what we are doing. But these are the subset of patient. I am not recommending for each and everyone. But yes, patient in critical ill organ failure, every 100 ml or abhi 100, some sort of fluctuation, these things matter in the management.
No, sir, that is true. Whenever we are dealing with such serious patients, every patient will be different. So it has to be tailor-made to the patient. So when we are discussing in a forum like this, we are usually discussing about topics which are very generalized. So we need to be careful because guidelines are also, we have a bell-shaped curve for guidelines.
More important, yes.
Yeah.
Because we are dealing with 80% of the mild pancreatitis, and
Because
rest we leave to
ultimately,
you.
then we end up with more procedures which are unindicated sometimes for the patients.
Thank you, panelists.